Topic is one step ahead, unlocking the full potential of semaglutide 2.4 milligram.
So, good afternoon, everybody.
Sir,
You know,
okay.
if you still have something, I don't need to any more introduction. Thanks.
May I invite our chairpersons to give away the token of appreciation to Dr. Hemant Thacker.
Right in the beginning, we'll do it later. Thank you. So, I'm interested in saying that when I drove up this morning, I saw that weight matters. Sure enough, for all these obese people in my country who've been waiting and dieting and exercising and going to gyms, they waited long enough. But as Dr. Jyoti Dev said, they came down, 3-4 months later, they went back. So you have waited long enough, and the world of pharmacology has now brought you something which will take you far ahead in your quest for weight loss. And this talk is not a talk in the diabetes symposium for diabetes, but it's for another disease, a disease which also is associated with diabetes. And you know that the world is getting fatter every day. How do I know whether I am overweight? Obesity kills. ABC to prevent obesity. Adopt new healthy lifestyles. Balance your caloric intake. Control your weight. But all this is sooner than later failing. These are my financial disclosures. Like Dr. Shashank Joshi said, I've been talking for a lot of companies. A lot of them have cross connections and competitions and things like that. So these are my talk and disclosures. The overview of my talk, like I said, is to fight this dragon. The dragon of obesity is something which we haven't been able to conquer. And this dragon is what we need to hit. Let us look at, you all know now what Wegovy is. What is the impact of Wegovy on body composition in people with overweight or obesity? It was associated with reduced total fat mass, relatively improving lean body mass proportion. I'll take you to step 1. The DEXA scan very clearly said that if you take Wegovy, the total fat mass proportion went down by 4%. So the lean body mass proportion went up by 3.5%. When they did a CT of the abdomen after using semaglutide, they found significant reduction in visceral fat area by about 40%. And in step 4, there was a reduction in mean waist circumference by a whopping 17 centimeters. So much of weight loss, so much of visceral fat loss, and of course the waist circumference. What is the effect of Wegovy on individuals with prediabetes or diabetes? It demonstrated very significant benefits. More than 8 out of 10 participants who were pre-diabetic demonstrated reversion to normoglycemia. That's phenomenal, because the A1C reduction was 1.9, and that we saw with Ozempic, where the mean A1C from baseline came down significantly at the end of 68 weeks. So 82% participants achieved A1C target of less than 7, and 72% participants achieved A1C target of less than 6.5. So everything was junked out. From the Coke to the burger to everything else, this was Wegovy. Let's look at obesity and osteoarthritis. This is something which is not often thought of, which is not seen, but my orthopedic colleagues are now sending references to me, of course with long faces, because the knee joint replacement goes the other way. And what happens? The effect of Wegovy on knee osteoarthritis related pain in people with obesity. It showed significant reduction in body weight and knee osteoarthritis related pain. And the improvements were seen in physical function without an increase in the use of analgesics with Wegovy. And the decline in the requirement of NSAIDs and acetaminophen with Wegovy was significant as compared to placebo. Therefore, weight loss and you have everything going your way. What about the clinical benefits of Wegovy? You saw all the data which Shashank gave you of the SELECT trial. I'm going to talk about a secondary analysis of the SELECT trial. You know, for those of you who are not from Mumbai, Mumbai has a great public transport. It's called the BEST. And in the BEST, we did a transparent version of the BEST to give you a cut view of the number of people, the type of people, and the central obesity in Mumbai. We've got people of all ages and telling you this is obesity even in the public transport users. What happens to MACE after Wegovyization? After Wegovy, you can see in the full SELECT trial, the first statistically significant difference was seen on day 20, as early as day 20. And the sustained significant difference statistically was on day 86. So look at the MACE induction of reduction after randomization. And this early MACE reduction preceded even the changes in body weight, which was considered clinically meaningful. So it was not the weight that kicked in first, but the reduction of MACE, and this is extremely important from the cardiometabolic point of view. And these benefits, which were observed within 3 months of MACE and 6 months for CV death, heart failure, and all-cause death, were very significant. I have outlined it in red, how MACE, CV death, heart failure composite, and all-cause death all favorably moved the needle. What about the other cardiometabolic parameters at early trial visits? All the lipid fractions, including triglycerides, systolic blood pressure, HSCRP, body weight of course, circumference of course, and UACR. Everything, the pendulum swung to the benefit portion. And I want to point out HSCRP. I want to highlight UACR. Now with exercise, with diet control, with mental agony and suppressing the hedonic eating, you have a fat chance of getting success. You need something more than that to hit the golden pot. Let's look at the secondary analysis of the SELECT trial with early clinical benefit. You can see the risk of MACE was reduced by 20%, and it was consistent throughout the duration of the study. This is important. It can't be a flash in the pan. It has to be consistent. You have to get the same result for a prolonged period of time. It demonstrated a sustained and significant benefit within 3 months for MACE and 6 months for CV and heart failure composite and all-cause death. And the early benefit of MACE preceded both clinically meaningful body weight changes and the titration of Wegovy to the target 2.5. Wegovy may rapidly improve the disease trajectory in patients with overweight, obesity, and CV disease even without diabetes. This is a diabetic meeting, but I'm talking about the consequences for patients even without diabetes. Of course, like the EMPA-REG study and the SGLT2, we are still scratching our brains. The underlying mechanisms for early CV benefit with Wegovy requires further investigations. We don't know. We can see, but we don't know. Little bit like the Air India crash. Now, we talk about the real world evidence with a select-like population. This is an interesting study called the SCORE study. In this, the SCORE study, it was a retrospective longitudinal observation cohort study. The data source is as given: overweight, obese individuals, more than 45 years of age, with previous CV history and no prior history of diabetes, were given 2.4 and non-users, and a follow-up period was initiated. The primary and secondary endpoints were the revised MACE-5, where coronary revascularization and all-cause mortality came in, the revised MACE-3. Of course, the secondary endpoints were MACE-5 and MACE-3. What happened in the SCORE, which was a select-like population? MACE-5, 35% reduction. Revised MACE-5, 45%. MACE-3, 42. Revised MACE-3, 57. CV-related mortality, 73%. And all-cause mortality, 86%. Sounds like a fairy tale, but it's true. It prevents your obese patient from not getting burgered if he uses what you give him correctly. What were the clinical implications thus of this real-world study? It was an enormous sample, not to replicate select, but to mirror, including the population that was there. The primary endpoint of revised MACE was 57%, secondary endpoint of MACE-3 was 42%, and select results are relevant in the real world, and SCORE thus suggests that the real world select population may even do better than the select reported. What about effect in heart failure with preserved ejection fraction? STEP studies with HFpEF and HFpEF with diabetes, there were significant improvements in symptom severity and physical limitations. You can see versus placebo how it moved in plain HFpEF and in HFpEF with diabetes. Again, if you see the 6-minute walk distance, HFpEF after 52 weeks and diabetes HFpEF, semaglutide outscored the placebo very significantly. So therefore, if you look at the composite heart failure and CV death data, in people with HFpEF, semaglutide versus placebo showed a reduced risk of the composite of CV death or first worsening heart failure event, a reduced risk of first worsening heart failure event, and no significant difference in the risk of CV death. So therefore, this shows that semaglutide is an efficacious therapy for reducing the risk of clinical heart failure events in people with HFpEF, where the clinical and current outcome therapies are limited. So therefore, for them, this is a change for a lifetime. I come to the last part, which is the benefits in MASH. This is very important, the ESSENCE trial. There are not many Indians who do not have fatty liver, especially if they have metabolic problems. So it's difficult to then treat them, to help them, and to answer their questions. We know that the phase 3 trial of semaglutide in metabolic dysfunction associated steatohepatitis. It was in two parts, part 1 and part 2. Part 1 results clear. In patients with MASH and fibrosis stage 2 and 3 demonstrate that relative to placebo, treatment with semaglutide 2.4 improves liver histology, lowers the risk of liver-related clinical events, and you can see the key two endpoints where the cirrhosis-free trial, the randomization, and the part 2 is still going on. And if you see the results, the histological evidence of steatohepatitis, where the evidence of fibrosis 2 and 3, what were the primary endpoints in the key results? Steatohepatitis reduction with no worsening of liver fibrosis after 72 weeks, improvement in liver fibrosis with no worsening of steatohepatitis at week 72. Of course, confirmatory secondary endpoints of change in body weight, resolution of steatohepatitis, and improvement in liver fibrosis. And of course, the change in 5F36 bodily pain. So metabolically, the dysfunction-associated steatohepatitis was also alleviated, and it is the first and the only GLP-1 RA treatment with benefits for patients with MASH and moderate to advanced liver cirrhosis. Twice the rate of patients on semaglutide 2.4 achieved both improved fibrosis and MASH resolution versus placebo. 37% improved fibrosis and 63% had MASH resolution. Truly, semaglutide had a living it the mashed up way, because semaglutide corrected the dysfunction. In summary, semaglutide reduces all-cause mortality and protects organs across patients with cardiometabolic diseases, all-cause mortality, transformative weight loss, MACE outcomes, heart failure outcomes, kidney outcomes, liver benefits. I'm not even talking about the osteoarthritis, but this figure tells you everything. This fat old man who has more hands than Ravana's heads is still juggling with his problems. He has an answer. There is a cause and then there is an effect. So the fat lady who came from out of state to Dr. Jyoti Dev's clinic now has a boyfriend. The obese people around have enough hope. And if you're obese, you don't have to worry, because whatever the situation in life, you can still enjoy your life. Wegovy is round the corner. Thank you for your attention.
Sir, for that excellent session. I think if time permits, we shall take 2 or 3 questions.
I now invite our chairperson, Dr. Jyotidev Keshavdev, Dr. Shankar Joshi, to give away the token of appreciation to Dr. Hemant Thacker.
Any questions? Yeah, please. Yeah. Come.
This will have to be still entirely analyzed, but it's obviously a positive outcome, because the weight loss is there, and along with the weight loss, inflammatory parameters and other things. But we do not have, like the Essence trial, all the data totted up.
Sir, I want to know at what age or what is the age limit we can start this Wegovy? In children, is it okay?
In children,
Well, I would be a little reluctant because, you know, on the label it is something else, but we in clinical practice do start in stubborn obese patients after the age of 21. I don't know what.
18, yeah. I think you can definitely start 18 years and above. And currently there are, Dr. Prasobh, there are ongoing clinical trials in children. And Pioneer Teens, it is ongoing, and that is oral semaglutide reverses in children, including 10-year-old population. So type 2 diabetes, obesity is becoming more and more popular, common in children. So the same drugs are studied in children as well. And there is data on liraglutide, and it is already approved for use in children. And that is the higher dose of liraglutide. So it is relatively safe, but not studied in pregnancy. Because when you are using in adolescents, when they are pregnant, you have to stop the drug. If they are planning for pregnancy, you have to stop. But there are millions becoming pregnant on semaglutide, but nothing is happening. So it's supposed to be safe even in pregnancy, but you are not supposed to use it. Shashank, you have to add?
So above 18, clear cut. Between 12 to 18, good data ongoing. Below 12, be a little cautious. But if somebody has brittle obesity, case-to-case basis, one can use it in a population below 18 as well. But that has to be an individualized off-label use. Currently, the label is very clear.
Michael.
The dose for obesity will remain the same.
Shashank sir.
It's not a pediatric agent right now. It's an adult agent.
Shashank Joshi sir.
Yes.
Sir, here sir.
Yeah,
Sir,
yeah.
we have seen the data on heart failure with preserved ejection fraction, both with without and with diabetes. Can we anticipate
Hello.
in future, can we anticipate a result on heart failure with reduced ejection fraction? And why the difference is there between with and without diabetes?
So I think this is again work in progress. What we should understand is every agent has unique proposition. With semaglutide, the unique proposition is weight loss, which is compelling, and cardiovascular and peripheral vascular disease data, which is compelling. The renal data, which was asked to Hemant, or the data which you are asking me now, is ongoing. So we need to recognize, but the directionality of it looks to be compelling. So very clear that, for example, SGLT2 inhibitors are heart failure agents. So there is no distinction there. But these agents are MASH agents, maybe they are brain agents, they definitely are heart agents. So we need to recognize that every agent will have a space in the disease modifying world. But currently, preserved ejection fraction data, reduced ejection fraction data and kidney data is work in progress. A large myriad of trials, both in the oral and injectable space, in the GLP-1 and the entire backbone therapy is still ongoing. But right now the answer is that we need to be fluid on this, and it's a question mark right now.
You can extrapolate some data from oral semaglutide and fit it in, because you know the experience on HFpEF and reduced. So you can extrapolate it.
Yeah, you have a question.
Dr. Jyotidev, I had given semaglutide tablet for reducing the obesity and met with a lot of nauseating effects, gastric and nauseating effects. So what about this injectable semaglutide? Whether it will produce so much nausea and upper gastrointestinal.
Yeah, because all the GLP-1 receptor agonists, because of its mechanism of action, by suppressing the appetite, you can expect this because it's rather than effect. Because I used to tell my patients it is an effect rather than a side effect. And this we have been seeing with exenatide, with liraglutide, with dulaglutide, and the prevalence is exactly the same, not more. It is exactly the same. In 10 to 15% of the patients, they might develop some amount of nausea or diarrhea, vomiting, and there are ways by which we can eliminate it. You can have a proton pump inhibitor, such as pantoprazole or so. Small frequent meals, eat only when they are hungry, don't overeat. And if they are using more spicy food, there is more tendency for vomiting. And this gets adapted very soon, you know, because we are starting at a dose of 0.25 and then waiting for 4 weeks. And if in case the patient is having some symptoms which are intolerable, you can either down titrate or you can wait for another 1 month before escalating to the next dose of 0.5. So it is a preventable one. So if you are smart enough in titrating, not just up titrating, smart enough in up titrating and down titrating whenever it is required, really required, then almost 99.9% of the patients will accept it, will tolerate it. So the GI side effects are not a serious issue because this has been experienced by all the members in the family, and there are ways and means by which you can overcome this. We can circumvent this.
Apart from this, any other major,
Pardon?
apart from the any other major side effects for this semaglutide?
No major side, because if you go to the media, there will be a lot of side effects described, and you know, when there is a weight loss, whether it is a weight loss with the medication or whether it's a weight loss with diet or exercise, there can be a particular percentage, 30% plus or minus 20% loss will be there for the lean mass. And that has to be addressed with nutrition, and that has to be addressed with exercise, including muscle strengthening techniques. And that is part of the therapy. So you require preferably a nutritionist or a multidisciplinary team to aid the patients. That we discussed yesterday also. So this is not a side effect of this drug, this is a part of weight loss. I think Dr. Shashank can narrate more about this.
So coming to your first question, and Dr. Jyoti, they very nicely explained, nausea, vomiting, diarrhea, constipation can occasionally be seen. This is a dose dependent phenomenon, which is why start very low, go very slow. Start very low, go very slow. When Michael Nock, he was a gastroenterologist doing endoscopies, he's the one who did the phase 2 seminal dosing studies. And he realized that the entire class, if you start very slow and go very low dose and then gradually escalate, there is a reversible issue as far as nausea vomiting is concerned. Once in a 50 or 100 cases, you might get a person with exaggerated impact and you may have to discontinue the drug. But most of the people, if you start slow, go slow, you will be able to overcome this and mitigate this. Number 2, before you start this agent, we must ensure that at least do a sonography of your abdomen to do and rule out gallstones and gallstones inside the biliary tract. That's number 1. Number 2, take a history of pancreatitis, or recurrent or old episode. And number 3, if there is a rare condition called multiple endocrine neoplasia or a familial thyroid cancer. If you want to play safe, you can do a liver function test with amylase lipase and a calcitonin to be absolutely documentarily safe. Because lot of these things come in social media, and therefore what happens is our patients are more educated. But does this drug cause suicide? No. Does this drug cause any eye issues? No. But these are real things which you should recognize. Remember, more than 200 drugs can cause acute pancreatitis. But if there are more than 3 risk factors for acute pancreatitis, even a simple paracetamol can cause pancreatitis. Remember that. So on the background of that, one has to be cautious. You are using a new agent, it is expensive, and therefore you have to be cautious in your overall prescription. Also, the last point which I want to make is, let's be pharmacovigilant. These are new agents, they are less than 5 years old. We can also report new and novel side effects. So if you see one, there is a very good medical team. Dr. Vijay has now come, she got blocked in traffic jam. You can report it to her team and she'll be more than happy to document it and send it to Denmark, because these are new drugs. But what we have seen is the advantages and the outcome benefit or the health gains of the drug far outweigh the negativities or the adverse events. Okay.
Overcome the nausea, vomiting, and then you can safely keep stepping it up. It's the initial month or 2 weeks, 3 weeks that you need to hold their hand.
Any anaphylaxis or articular reaction? Any anaphylaxis or any other skin reaction?
They're both of you talking, so it's difficult to understand.
Yes, there is ongoing data in this space of Parkinson's disease, cognition, dementia and Alzheimer's disease.
Alzheimer's.
But this is under investigation. It is currently experimental, and you will have this data as the quadrangle of care. So this is, I told you, triangle of care: heart, kidney, liver, and the quadrangle of care will be brain. But brain right now, if you ask Novo Nordisk, they say it is off-label. If you ask Eli Lilly, they'll say it is off-label. Currently it is off-label, but it's exciting times. Excellent data in the both animal and human space, which is ongoing. If you were there at Chicago at ADA, good data. Right now, San Francisco Endo Society is happening, good data ongoing. It's work in progress, some exciting data.
Doctor, you have used oral semaglutide. There is data of oral semaglutide with Alzheimer's, cognitive. So you have to put 2 and 2 together, and your maths will not make it 5, it will make it 4.
Any anaphylaxis in injectable semaglutide?
You need to improve your speech and speak loudly.
Any anaphylaxis to the injectable semaglutide?
Anaphylaxis, no. We haven't seen anaphylaxis, at least in my clinical practice. I don't think Novo also has reported. Yes, you take it on a Sunday morning. Initially when you begin, you might have Monday, Tuesday, Wednesday, the guy eating nothing. But that can slowly, outcome will go away.
So your experience on patients with hiatus hernia with this drug? Those who
Hiatus
already have it.
If you already have a hiatus hernia and you initiate the drug, and if he has lot of vomiting and nausea, you can exacerbate it. But otherwise, it's not going to cause. In fact, if you lose weight, GERD, OSA, everything goes away. So if GERD goes away, OSA reduces, your cognitive function and your hiatus hernia both will abate.
In December this year, so it will be treatment for diabetes as well as for obesity, predominantly obesity from 11 years onwards, and step young is going on from 7 years onwards. 6 years, so it's going to be in children as well. So it's going to be there in all these specialities.
So one more question to Jyoti sir. Sir, whenever such a new drug come to the market, the common layman's always query is regarding the abdominal obesity. All of them know the abdominal, what a relative proportion of fat loss, especially when it comes to the abdominal obesity. Any insights on that
I have
aspect?
shown the data on 15.
I showed you a slide. 4% fat mass goes away, relative lean goes up. 17 centimeters of your abdomen gone. What about visceral? They did a CT scan of the abdomen to show you ablation, 40% drop in visceral fat. That's phenomenal.
I have a question. How safe is this drug to use in patients who have got diabetic retinopathy and macular edema?
Diabetes, retinopathy, macular edema. If he is obese and his diabetes is also a little out of control, there is no contraindication in macular edema or retinopathy, because if the retinopathy is also accentuated with a little bit of systolic hypertension or abnormal lipids, everything will improve.
I would say, no, your question is absolutely correct. In the ocular space, when you get rapid glucose control, sometimes a caution is exercised with any agent. It is not specific to a semaglutide or anything, but you need to be cautious that if you have an underlying proliferative retinopathy and or a active macular edema, you need to have a close dialogue with your ocular colleague. But sometimes remember, rapid weight loss stroke rapid glucose correction in any space with any therapy can be deleterious, and that's something very well recognized, but it's an exaggeration of an effect. And I think all we need is a good ocular vigilance in that space. Most of the times things are self-limiting, and most of the times the therapies are, given simultaneously. So the macular edema will get their injections, the retinopathy will get their laser stroke, their surgeries. So this all goes in sync. And you're absolutely right, it's a valid point. So one has to be cautious. All we do is ensure that the ophthalmologist regularly sees this evaluation. but sometimes rapid glucose control that can occur with insulin also, or rapid weight loss can sometimes aggravate.
But in the two areas we have to be careful. One is it results in significant reduction in the blood pressure as well. So you may have to reduce the dose or eliminate the dose of blood pressure medications. And the example of a person I have shown, I have actually reduced and stopped the basal insulin and then eventually all the insulins and all the drugs for treating diabetes. So these areas we have to be careful. Retina also you can examine because
I have
there is some
actually
data.
stopped all the drugs.
All the drugs.
In
So
many patients, except antiplatelets and statins, all the drugs, blood pressure and glucose drugs have gone away with these agents.
one more question, yeah.
Yeah, there was one more question at the back here.
Hello?
So that verdict is,
yeah.
verdict is not out. That verdict is very conflicting. Two data sets which are retrospective said it's positive. Two more data sets said it is neutral. So verdict is not out on that. So as I said, it's a unique opportunity to be pharmacovigillant. You know, if a drug works, it will have effects and it will have side effects. It depends on how we report them and how vigilant we are.
Actually, we have written a review in JPEF on non-antidiuretic anti-ischemic neuropathy, and this is non-significant. Currently, there is no significant association. It is a very, very rare association, considering more than around 40 to 45 million users around the world, because this drug is not new. Injectable semaglutide is around for close to 8 years now. It has only just reached India. That's the only difference. Last question.
Hello?
Yeah, yeah.
Hello, this semaglutide, what I understood, oral versus this this injectable with regard to the weight loss, why this great disparity as I have understood? Oral versus, because
very
for
tough
non-diabetic weight loss,
Yeah,
I
we
understood
got a
that only
question.
parenteral is considered. Why?
So we got a question. So point is that oral semaglutide has 3 milligram, 7 milligram and 14 milligram. So you can't up-titrate it, though Novo Nordisk is developing 25 and 50. While in the injectable space, we can upgrade from 0.25 to 0.5 to 1 to 1.7 to 2.4. So the up-titration is possible, which is why the weight loss is more, while there is a saturation point at 14. 14 milligram of oral semaglutide is equal to 1 milligram of semaglutide injectably. So obviously, we are not able to go beyond 14 milligrams. So if you are getting a class of patients who cannot get that impact on 14 milligram, you still need a 1.7 or 2.4, and that is why you see that differential. When 25 and 50 will be available, then obviously you will see that even this part will be mitigated. And as I said that the injectable compliance might tend to be better, but of course
oral is a peptide in a pill. So they have gotten over the absorption problem by putting the peptide with something else to
Snack.
allow absorption.
Snack.
Yes.
snack.
But with that SNAC also, the amount of drug absorbed is going to be varied and limited. While with injections, you're going straight into the system. And a lot of people, as much against your thinking, prefer injections, which is once a week, rather than getting up every morning. 20 minutes, take that small glass of water and have that pill. They prefer the injection. More drug, more easy, compliance is better, weight loss is more.
So let me make one thing clear, that oral 14 mg is equal to 1 milligram of injection. The impact is the same. In oral trials, RCT evidence, and injectable trials, RCT evidence, both for diabetes and obesity, there have been some directions, sometimes in the same direction, sometimes in a little conflicting direction. This is work in progress. But as we speak, even in India, 25 and 50 milligram oral tablets are there. I agree with Hemant in many ways that oral has its own challenges as well as its own proponents. But one thing is there, that the snack, which is the absorption enhancer, takes the snack away and you don't snack anymore. And I'm happy that so many people, despite of your hunger pangs, are staying here. So many of you all are on Wegovy.
The higher dose of oral semaglutide is studied in Viasis clinical trial, and that could be a drug in obesity. But currently, the approved drug in obesity is injectable semaglutide, not the oral one. Oral still is very good, and the clinical trials, including the MACE reduction, is there. There is cardiovascular risk reduction with oral semaglutide, but it is more of use in type 2 diabetes. So, but this one is approved in obesity as well as in diabetes globally. I
So-
think we.
So I think it's time to wind up the session.
So let me have one more word. The theme of JPEF 13th edition is weight matters. So it is worth the wait for Wegovy. So thank you.
Okay,
Over to
thank you. It's time to wind up the session. Hope we had a excellent, fantastic session, and thanks to the speakers, we had an elite panel, Jodev sir, Thacker sir, and Shashank Joshi sir. Thank you very much.
Thank you, dear chairpersons and speakers.